Welcome back to the True Sports Physical Therapy Podcast. Today's pod is going to be totally different than anything we've ever done. We're always trying to bring you the latest and best content in the most digestible way. And so what we did yesterday, we had a huge snowstorm up in the Northeast and really probably all of the East Coast. And what we did was we got the entire team together. And we did a Zoom call with Dr. Jeremy Beyer, who's our head of clinical excellence here at True Sports. And it's going to give you a wide-ranging look into, a lot of the things that we do at True Sports to make sure that our clinical game is always up to par. And so you're going to hear from a bunch of specialists, including people who have created actual course content for True Sports University. So I encourage everyone to go in there and check it out. But you're going to hear from Jeremy talk about things, as always, like ACL, rehabilitation and recovery, things that you need going in to surgery, coming out of surgery, what to do when the knee is stiff, when to push the panic button, what that panic button actually means. We also hear from Dr. Austin Colish and Dr. Rachel Noble, amongst many other experts, talking about Achilles, ruptures, repairs, Achilles tendinosis. You're going to hear about things like AMI. You're going to hear about blood flow restriction, dry needling, how to progress your patients, how to scale them. So many topics covered here. And what I'm really interested in from the audience out there is hit us up on Instagram and just let me know what you think about this format. I think there's a lot more we can do here. And I want to know what you guys love, what you hated. As always, True Sports PT on Instagram. And then check us out online, truesportspt.com. And you can find all of our educational material, including some of the experts that I just mentioned. Without further ado, here is Dr. Jeremy Beyer leading a team of experts at True Sports. Enjoy.
Okay. So the first question is, again, like I said, big ticket clinical or big picture clinical question. So how do we define success in rehab? And I want us to all pause and take a minute and think about that. How do we define a successful rehab?
I think a lot of it relies with the patient in subjective feedback. As much as we'd like to be as objective as possible, I think Julie was saying, like, hey, can you lift your kids pain-free? Or what do you want to accomplish out of PT? I think is a really important question to ask after evals or during evals. Like, hey, what do you want to get out of this, right? And, you can't always put something objective to it. Sure, if you want to pick up your kid, you could estimate your kid weighs 20 pounds and can you do X amount of reps of it? Yes or no. But if that doesn't translate to real life, I don't think it's going to have as much impact as a successful rehab as you want. And then outside of that, the insurance answer would be like, yeah, objectively, right? Can we take a quick dash or an LEFS or an oswestry that says like, yes, we've objectively gotten better and we feel like we are objectively back to that 100% according to this questionnaire. But I think the subjective is always going to outrule the objective in certain aspects of like how successful was this to the specific patient.
The key thing you mentioned to me there was that it's so patient and athlete specific and just getting out of this objective mindset. Does anyone else have anything to add on top of what Pat said?
Yeah, I think the big thing is, yes, getting them back to everything that they want to do, to kind of pivot off of what Julie made a comment, just getting them back to what they want to do safely and well, but also how to be proactive and basically show them how they can take care of these things in the future, I think adds a lot of value to success so that, we are facilitating independence, yes, from day one. Obviously, that's not the primary goal, but I think if you're setting yourself up well for the future and, constantly reinforcing this person, like, hey, whether it's this nagging shoulder issue with like pressing or, this knee with a long rehab to get back to sport, like now you have all these things to really help you long-term. And hopefully you were just a lot of education for this person to understand their body a little bit better and just how to take care of themselves better in the future. I think that's also successful. They can walk away and they have all these tools to succeed now and they know how to take care of themselves a little bit better.
Absolutely. And it starts on day one. Other individuals. Yeah, just to kind of tie that one home, I think to me, I'm always thinking about one of the best things I've heard is it comes from like the late Stephen Covey, the 7 Habits of Highly Effective People, of starting with the end in mind. On day one, we need to know what the individual is trying to get back to doing, because ultimately that's what informs success and ultimately our interventions. And so starting with the end in mind, what is a patient want to get back to doing? You could have the same type of pathology, ACL rehab, but approach it very differently if this person's a high-level athlete trying to get back to sport, or this person just wants to kind of be pain-free and play and do general pop stuff. So I just think that understanding context, the patient in front of you, is so important. I think it's not for us to define success, but what are the goals the individual is working towards? And what do I need to do today to get to where I need to be tomorrow? What do I need to do this month to get to where I need to be next month? And always asking those questions, where am I and where am I trying to go? So great stuff on the first clinical question.
Jeb, before you move on, Jeb, we think about success so often in terms of discharge, right? And then I look around some of the clinics and we got patients that have been with us for 2 years, right? So how do you guys think about a longevity of a patient and keeping them going? I know Sarah does a lot of this in Bear Hills. Tim's done a lot of this certainly in Woodbine, where the patient is there for a very long time and still trying to demonstrate success versus what standard PT is saying, hey, 12 visits, 15 visits, and you're fixed, or at least you know enough to move on. How do you guys kind of reconcile those two scenarios? Let's go with a vet. Kendra, what do you got?
Well, I think like one of the biggest things is when we're saying what the patient wants, that changes day to day and that changes week to week. And I think part of being a great physical therapist for life and showing what our profession can do, which is be a constant in someone's life, is being able to adapt with them as their life changes. And that can be like an athlete where maybe they had a big injury, like an ACL, and they decide they actually don't want to play lacrosse again. They would like to switch and maybe play golf or something like that. Or that could be someone middle-aged that had whatever injury, and they're like, hey, as I'm getting a little older and my body's changing, I still want to stay active. And so you can be accomplishing their goals while keeping them on your schedule at the same time, because day to day, week to week, year to year, their goals are changing. And so you're just adapting with them.
I think it's a really good answer. I think you got to be nimble. Jeb, done hijacking. You work the raised hands. Thanks, Kenny.
No, this is a lot of raised hands. We're getting a ball rolling. This is good. Let's go to Nick.
Yeah, I think of in terms of kind of like piggybacking of what she was saying, but also I guess the first thing that comes to mind is I have there's 4 or 5 tennis players that come in and they're playing tournaments throughout the year and they're dealing with different things come up. This week kind of tweaked my ankle, or some weeks nothing's going on, and it's then it's more of put kind of more the strength and conditioning hat on and knowing their previous injuries, trying to injury risk reduction, getting them healthy in those spots and trying to be as resilient as they can. So the past injuries don't come up again. So then I guess success, I guess in that instance is more of being able to give them the best chance to play at the highest level they can. And then also improving their performance with strength and conditioning.
Excellent. Let's go to Zach.
Sorry, I had to turn off trash truck for a little bit. So just putting a billing plug in here too. So for us to be able to see our patients for that extended period of time, we need to be very efficient and do right by the patient and do the best we can to justify medical necessity, even though yes, they are jumping, cutting, sprinting, and it's their insurance based off of maybe Aetna and Ash's standard, they've been set for years, but being efficient and being very creative with how we document.
A well-deserved billing plug. Yoni won't complain about that one. And then how about our last one, TJ, and then we'll move on to the next question.
Yeah, I think it kind of goes off of what Kevin had mentioned too, is that they realize goals later on that they might not have. And I think Kendra mentioned it as well. But especially these longer rehabs, like they're not going to trust anyone more than you if you've been with them for 8, 10, 12 months. And so they trust you with, the return to sport. You know them better than probably anybody else at that point. And so it's a really testament to what we do as a company and, the model we have that we can keep doing that at a high level, that people continue to come for years, whether it's like Kendra said, if they, sprain their ankle after ACL surgery during the next season, or there's still some deficits or sports performance that goes on. We have a pretty big level of trust in their life. And so they're going to trust you with their performance goals, which I think is pretty cool, where we said like their goals might be like, okay, let's go to return to sport. But by the time they get there, their goals have now, raised the bar in certain areas. So we get to do that.
TJ, you said trust like multiple times there, and I think it's so impactful. Like, what better way, like from a successful rehab standpoint, earning the athlete's complete buy-in and trust is to me like a huge part of a success in rehab, because we can't always control the outcome, right? You can have a great process, a great decision, and a really unfortunate outcome as far as like re-injuries, but the trust usually goes hand in hand with the process. And I think it's something that we need to do, is make sure that the athlete is trusting us and bought in at all points throughout rehab. So really good stuff from you today. I do see Sarah, you have your raised hand. You want to add something, Sarah?
Yeah, I think for me, like a lot of it is you'll see an athlete. So like if you take an ACL day one and it's like day one, their main goal is just to get back to playing. But if you gauge success on that day, that's like 9 to 12 months from now, it's hard to like show them how rehab's going. So what I tend to like to do is like on day one, break down kind of like the general timeline of rehab and say it's like, hey, I want to get you running by this day. I want to get you changing direction by here, just so that once they make those little accomplishments, they can see like, hey, this rehab is successful. Now I've done this, and like outlining steps in the way. So it's not just their end goal, but it's all the little baby steps. So they know like, hey, I'm moving in the right direction. So I feel like just breaking that down and creating little goals along the way with them, because they don't know what to expect out of rehab, helps to show them that like they've been on the right path and we're actually getting them to where they want to go.
And it's daunting, right? Like if you look at the whole timeline from post-op all the way to return to play, there's so much to happen. It's overwhelming. And so without those small little goals along the way, you get lost and you can easily find yourself drifting off. So, okay. Thank you all for your contributions on the first question. We're going to transition gears to this next clinical topic. And that is, how do you decide when to operate with a medical versus a performance lens? And I'm going to John Harned to kick us off, because I think John does a great job of being able to kind of stay between those boundaries and really doing a great job of managing the performance side of things.
Yeah, I think throughout the course of a rehab, you're probably going to sway to both sides of these frameworks, from the medical and then performance-based throughout the rehab. Obviously, the beginning stages are often very medical-based. Like, for example, take a post-op ACL, short-term, right? We're getting extension back, pain-free loading, and things like that. I think when you're trying to decide when you can do that is like understanding, like looking at that athlete, what are you seeing? Right. Obviously, we have our objective measures that we're getting baseline testing on, passing the look test. They feel comfortable. I think when you're able to decide if you can fully start to begin that transition and make that transition is in your rehab session, giving them a little bit of extra, whether it's, a quicker based loaded movement or quicker based plyo, and just understanding how they tolerate. And again, like anything, you have an appropriate ramp up, right? If you first start running with an athlete, you're probably not running with them once and then unleashing them to a full return to run. Whether you're going to go time-based in the clinic at first and then progress that a little bit more at the clinic or speed it up, you're going to give them the healthy dosage of some form of middle ground where you're going to be able to decide, all right, I think they're ready. And then obviously when you make that call, start small with your performance-based testing or your performance-based measures to see that tolerance in real time, understand that tolerance after a session, versus going full blown, right? Straight from like your basic loading parameters to, a heavy plyo day, like understand where your ramp up is going to be, and then progress that over time. And there's going to be times like I've done this, right? I'll be open about this where, the athlete's feeling good. You've done a couple sessions of performance-based stuff and everyone's feeling good. And then, the next day they might be like, hey, like it's a little uncomfortable today. And like understanding when to scale back and reassess how you manage that progression. But there are going to be times where you might be in that performance-based stuff for a little bit. Athlete, comes back, they, tweak something, then you're going back to like the, in quotes, like the medical framework to kind of calm down that area, but then reintegrate back into it. So I think like how you're going to make it is your objective measures, looking at what's in front of you, subjective, observations from the patient, they feel good. Key takeaways for me are like no real pain the next day. They're not feeling like a sensation of pressure in the knee or the shoulder, the elbow, like whatever you're rehabbing and things like that. So.
No, John, you bring up a lot of good points, and it's really not an either or. It's more of a dial than it is like a light switch, And so, as John kind of alluded to in early stage rehab, you're going to go in with a high medical focus, right? That medical dial is going to be very, very high, and the performance dial is going to be very, very low, because there's a lot on the line from a medical standpoint. We need to have a good understanding of differential diagnosis, red flags, when to refer out, when is this not for PT, and this requires, physicians, so infections, things like that. So we go in based on training with a high medical focus, but then the further along we move along that return to sport timeline, we have to transition more towards that performance. And so it's just understanding, okay, what are the risks? What am I missing? And going from there. Any other individuals on that specific topic? Excellent. We're going to do one more big picture clinical topic, and then we'll kind of get into some more of the clinical pearls and rehab specific cases. So last question is, how do you make good clinical decisions when there are high levels of uncertainty present? And so we talked a lot about this last week with our Return to Sport decision-making journal club, and understanding risks, trade-off, complexity, and embracing the gray. So when we go through evals, there's a lot of times where we're not exactly sure what exactly is wrong with this person. What's the diagnosis? How do we confidently come up with a rehab plan for the individual while still conveying the uncertainty and complexity involved in the process? If anyone has any experiences, cases they like to share, or just advice on how to manage uncertainty in rehab, I think that'd be great. Because I think this is something I know I struggled with when I was getting started, is embracing that and still trying to come up with a plan. So would love to hear from some individuals on this one. How about Austin?
Yeah, so I'll kick us off. This question makes me think back to my first days as a staff PT in Timonium, and shout out to Chelsea Kuhlman, who was my clinic director at the time. In my onboarding in that first week, she made it very apparent to me that if I needed anything, whether that was like during an actual eval, like to feel comfortable, step out and lean on my teammates. So I think it's really important that everyone on this call here understands that, one, that is an integral part of our culture here, and very much something that I like to preach to all of our staff, and something I still see happen to this day. And I think that's it's important for everyone to understand that, like, that goes upward, that goes downward as well. Even now, like, to answer your question, Jeremy, if there's something I'm struggling with, I lean on my teammates. I know the number of conversations I've had with you and our Timonium team around force plate testing, understanding those metrics, being able to deliver the best return to sport criteria to patients as well. I think the other side of that is, if you're a newer clinician and you're coming in, just know that you have an immediate team around you, whether that's more veteran staff, your clinic directors, or other people in the same boat trying to figure that out. I think it's really important that we wrap our arms around that culture piece.
Excellent. One thing that Austin said that I want to talk on, and I'm going to go over to Andrew, is just patients don't care that if you were the one that got it right. All they care is they got better. And so if a patient comes to me and I say, hey, I need you to go see this doctor, they're going to be so happy that I put them in the right position, because patients don't want to be confused and lost. But that's one thing I just wanted to add. Let's go to Andrew.
Jeremy, you referenced the journal club we had last week or 2 weeks ago, and that was on, for those of you who missed it, it was on risk assessment and risk mitigation. And it actually really is a really good article. It gave a framework to something that I've had in my head since I've started doing sports PT, and it was check as many green boxes as I possibly can to minimize the risk of this person getting hurt on the back end. It's never going to be foolproof. It's never going to be 100%. But if you can check as many green boxes for return to sport as possible, you know, that 95% symmetry, has it been, and this is for ACL, I'm using examples for, has it been greater than 9 months? What do they look like from a pain standpoint? If you have all these green boxes checked, you are decreasing the risk of them getting hurt again or successfully returning to sport. The other piece of that too is how much risk are they willing to take? Is this someone who is a professional athlete? This is their livelihood. This is their job. Their risk threshold is a lot higher than a high school sophomores or high school freshmen. They're willing to go back to sport a little bit early because they have to, because it's a contract year. Is a 13-year-old kid who likes to play soccer or likes to play lacrosse and they're trying to make a high school team. That risk assessment's a lot different than someone who's, you know, fighting for their livelihood or something along those lines. And then when you talk about that risk assessment in, you know, your eval, a lot of times that's eval day. I'm asking this person, how'd you tear your ACL? What happened? What is it trying to get back to? Building that rapport, which we'll talk about a little bit later, building that rapport is key to finding out what exactly it is they're trying to get back to. So you can understand where they're able to take risks, where they're wanting to take risks, and where it's appropriate to. I'm not going to send a 13-year-old back to sport at 6 months because they are trying to make a high school team, unless everyone, including doc, parents, and the athlete, are on board. And even then, I'll give my professional advice of like, hey, this probably isn't the smartest thing to do, and your risk re-injury is a heck of a lot higher than it should be.
One thing you said, Andrew, that just rang with me is asking better clinical questions. And so often the right question unlocks the answer. It's been said that like experts don't have better answers. They just ask better questions. And that, to me, it's just like, okay, that context is all shaped by questions. So great stuff. Let's go to Sid.
So I have a real life example that I think would be really helpful to share. I have a patient right now who, when she first came in for her eval, she had seen 3 different docs for a knee injury that she sustained at work, and they all had very different opinions. She had imaging done. She had seen them all. But the biggest issue that I had is that none of them had actually put hands on her and ran her through tests. All they had seen was, here's the MRI, here's your complaints, here's what we're going to do. But it was so different to the point of like, one was going to repair her ACL. One was looking at no ACL involvement at all. It was like very all over the place. And she was like so distraught because she had no answers, or she had every answer, but none of them were actually pointing her like towards what this recovery was going to look like to get her back to work. So I spent that whole first session with her, like talking to her, running her through sort of just like a wide range of special tests, like hands-on, trying to get her at least some kind of an answer. We kind of came to a conclusion together just based on what I was seeing. And I also referred her to a doc that I trust. I didn't know these other 3 because she had to go through like workers' comp kind of stuff. So I put her in touch with a doc that I knew and trusted and knew would take the time with her to like listen to her, actually take a look at her, maybe even get another image. Cause at this point it had been like over a month, because the first one she saw was like, yeah, you just have a fractured patella. Like, here's a brace, don't walk, whatever. Okay. And besides like that little bit that we technically did, she like walked out of there feeling way more confident about like what this process was going to look like, even though she still didn't have a solid answer. I didn't need to know, but sometimes you just need to like listen to them and put hands on them and give them a better idea of what's going on and what this could look like. Or in my case, like referring her to somebody that I knew and trusted to take better care of her. And in her mind, it was like crazy that she had seen 4 docs, but the one that she ended up seeing ended up giving her like way more solid answer, scheduling her for surgery, things like that. So I just feel like a lot of the times, like we do get such variable reports and things like that, especially when people are coming from docs maybe we don't know, or other PT places, whatever like that. But I think it's super important to like take the time to be with these people and like run them through very basic things. Like try and figure out, like you're in PT school, like what is this quote unquote fake patient in front of me presenting with, whatever, put that into real life. And now you can actually help people with just very basic things and just give them like something to hold on to, rather than like just letting their head kind of spin in this kind of crazy like scenario that they could be in.
Sid, how did you, because she had been to multiple doctors before, right?
Yeah.
So how did the conversation go of you, like, you had a doc in your mind that you wanted her to go see? How did you make that suggestion, referral, while not being dismissive of her experiences with other doctors and kind of walking that tightrope?
Yeah, it was hard because, again, like she had seen 3 other docs who had looked at imaging and had, I think the thing that helped was that they all had such different opinions, and she genuinely had no idea what was wrong with her knee. So in her mind, when I first suggested it, she was like, is this person going to agree with Dr. A, B, or C, or are they going to be a completely different D? You know what I mean? Like, so she was definitely hesitant at first, but again, I think what helped was that I was able to like give her my own opinion of what I thought was wrong, instead of just being like, well, I guess we'll see, and like sending her off to somebody else, but taking the time to try and give her an idea of, hey, I really think this is meniscus. Like maybe there's some laxity in your ACL, but I think your bigger problem and where more of your symptoms are here, here, and here, like using those like images and things like that. She's one of those people that's like very Dr. Google and had like looked up everything too. So every report that was coming in from MRIs and from her like post-visit reports and things like that, like she was like getting the lowdown on everything that could possibly be wrong with her. So I tried to give her like, this is what I think is wrong, and this is what we're going to do about it, and this is the person that I want you to see, to either support or like figure it out. Like this was a doc that I knew would point her in the right direction. But it was a hard conversation because, again, like she was like, is this person just going to give me more BS, or is this person actually like going to help me and give me a solid answer? Because she didn't even know what to believe. So I tried to get her to believe me. And I think that's what kind of set that referral up for success, was giving her, like we've kind of already mentioned, like that trust, like establishing that from day one with that conversation with your patient, set her up for success to be where she is now in her rehab process.
Yeah, thank you. No, that's a great real world example. Dr. Google. I think we all have had our fair share with those kind of patients, but excellent trust there and awesome work. Let's go to Christy.
Yeah, mine kind of goes off of Sid as well, but I've found overall, as long as you present it in a way that's very thoughtful, as long as you have a good eval, you really get their subjective, you see where they're coming from and what you can identify. I found that most of my patients have been fine in cases where I've had to give them differentials because it shows my mind's working, right? I'm like, look, like symptom A, B, this could fall into this category. Symptom C, D could fall in this category. Like, here's our plan moving forward based on what we're seeing. So I think of my like a concussion, post-concussion syndrome coming in. Their dizziness could be caused by quick head movements. It could be caused by like vestibular. It could be caused by ocular. It could be caused by the neck. Here's what we're seeing. If you have double vision, is it an eye issue or is it something that we can work with? So I kind of give it a timeline. Like I give you this stuff. If this, your ocular stuff doesn't resolve by this amount of time, then I'm going to send you to a doctor that I have planned, or we're going to look into this basket of things. So overall, patients just want to feel like they're being listened to and they want to know that your mind's working. Often, if patients go to someone like Sid was talking about, her patient went to all these different doctors, often doctors are like, it's definitely this, it's definitely that. And then it gets very overwhelming when you go and you get these different opinions of people who are like certain that it's one thing, even if it may not be. So as long as you're presenting that well and presenting it with your own knowledge and like being confident in what you know, but also recognizing that if there's something you don't know, that you have a plan moving forward and kind of give that person a timeline and organize it.
Christy just captured everything I wanted to in this question. She talked about the value of like speaking or thinking in systems. Like when she was talking about this could be because of A, this could be because of B, this could be because of C. That's exactly what you want to do when you have a patient. If a patient comes in with lateral hip pain, you want to explain all the things that it could potentially be. That is so important. And so one of the questions that I always ask is, how else can I explain what I'm seeing? Right. And that prevents me from getting locked in on like the first pattern that I think it could be, because the more possibilities that it could be, the more likely you're going to say, all right, there's a lot of nuance and uncertainty here, and you're going to be a little bit more smart with your decision making. So excellent stuff, Christy. Let's go to Gina.
Christy wrapped up well what I was about to say in terms of the timeline. I think the best thing that you can do with these people is give them a timeline from day one. So if you've done all of your testing in the beginning and you are in between two things that could be potentially a referral out versus something that you think you could handle more so in-house, you want to be able to say, in 6 weeks, this is where I want us to be. This is everything I'm going to test until that point to know if that you're still in the right room. If not, I already have it lined up and potentially already set up for what imaging you're going to be going to or that ortho I'm going to refer you to. And I think that that gives you so much buy-in from the beginning. And it, like everyone said, it lets everyone know that you're thinking constantly and you can continuously educate them each session as to how they're either tracking towards those goals, not to mention also get buy-in by spending part of their time working those accessory things that they're going to need if they go into that surgery anyway. So they already know they're in the best hands that they could be.
Excellent. Gina, we'll go to Julia, and then I'll mention something that you said that I think was really, really good. Julia, let's hear it.
Yeah, so one thing to like just keep in mind is also what to say when there's a setback, because that's one thing that we have to deal with in the field when it comes to uncertainty. You know, I mean, some patients might be walking in the snow and suddenly they're walking on uneven surfaces before they're ready, and they might show up to our clinic on, you know, Tuesday, Wednesday in more pain than expected and suddenly have less range of motion. I think it's important to just remind them that, you know, sometimes things will get flared up and we're going to handle it. And as long as you're doing the exercises and modifying in these ways, if you're having a flare up, you're going to keep moving in the right direction, because sometimes they get discouraged in those moments. So just having something in your back pocket for if things get flared up, if things get agitated, if we need to make a slight pivot, to keep them in good spirits, and also knowing that like there is a way forward even in those moments where they might get discouraged.
Yeah, there's inherent non-linearity involved in the process. And I try to, utilize real world examples. If someone works in finance, I'm referencing the stock market. If someone works in, travel, when do flight plans ever go exactly according to plan? Or, a lot of people do construction, and anyone who's had their house renovated knows that these things take way, way longer than expected. And so I think when you mention that these things are going to happen from the start, when they do happen, it's like, hey, remember when we talked about that? This is all part of the process, versus it's like, it kind of avoids the whole freak out. But thank you, Julia. Gina, real quick, the last thing that I wanted to talk on that you said was from day one, giving them the timeline. I think that's so important. Is remember, when patients come to us, our goals are to establish a plan of care. Right. And I think we get students oftentimes that come in and think, what exercise am I going to give the patients? The exercises are just the parts. We need to think about the plan of care and how do the exercises fit into that whole thing. And so prognosis is so important. That is the value of coming to physical therapy. It's not just to do some exercises. And a lot of times I have to tell patients, I'm like, hey, this session, just coming here is not just a workout. I'm not a personal trainer. It is to have a plan of care, give you clarity around the situation, and get you back to where you want to be. So I think it's just important to remember it's thinking big picture. And hopefully these questions got us thinking more overarchingly about what we do in rehab. Any questions on or questions on those kind of big picture items before we get into some more of the clinical pearls and more specific clinical topics? Excellent. Okay. Our first topic was submitted by Nick from Bethesda. So thank you, Nick. And it is on Achilles tendon ruptures. Okay, so I wrote down a couple questions. I think we can get the ball rolling, but certainly if you have any questions on Achilles tendon ruptures, let's hear it. The first question is going to be, how do we know when a patient is ready to discharge the boot? All right, I am going to go to Rachel Noble.
Sorry, I just want to make sure I heard you correctly. You said discharge the boot.
Yeah. So we have some great questions on Achilles tendon ruptures. The first one, I think there's I'll just preface it. And so protocols around Achilles tendon ruptures are all over the place. Some are really aggressive, some are really conservative. There's often these vague timeline-based criteria regarding when to discharge the boot. And as we know with timelines, there's inherent level limitations. And so when to discharge the boot is a key milestone in Achilles tendon rehab, in my eyes. And so I want to learn and ask you all, when do you see or when do you determine readiness to discharge the boot in your rupture patients?
So I think the first piece would kind of be understanding what protocol that surgeon has in place as far as like heel lifts kind of go. So a typical like rough protocol I've seen is once a patient's transition from non-weight bearing to weight bearing inside of a boot, they're going to have X number of heel lifts inside of that boot to essentially reduce the time they spend in dorsiflexion. And then over the course of time, maybe every 2 weeks, you're reducing the level of the heel lift within the boot. And then the question that I typically don't see consistency on within surgeon to surgeon is the transition from the boot to the shoe. If they maintain some sort of heel lift in there, which I typically make sure all of my patients do, but some surgeons are more specific than others in that regard. But that's kind of my first thing is like, okay, are we transitioning to like what level of heel lift do we have in that shoe in that transition time? And then from the standpoint of like, when do I feel comfortable with them doing it? I'll kind of follow that typical timeline, but then I'm watching their gait in clinic. Typically, you're going to see like that lack of push off gait mechanic where they will essentially almost like miss the like midfoot rocker, where they almost just kind of like go heel and then they just pick up the foot where they don't have that like natural sort of like weight progression forward into like plantar flexion and push off. So mechanically, that's something that I'm kind of working on with them in that transition period. I'm also kind of looking at like obviously their overall confidence levels. At this point in time, they're not able to complete like a single leg calf raise at this point. But there is an interesting paper that I can share with the group if anyone's unfamiliar. It's by Josh Baxter et al. It's essentially a loading tier of exercises and load on the Achilles tendon. And it compares like double leg calf raises to the amount of force that goes to the Achilles tendon with walking, step ups, like step downs, different things like that. And it's a helpful sort of framework of, okay, if I'm telling someone we're progressing out of boot, I need to make sure we're simultaneously loading the Achilles tendon appropriately with exercises. And if they're able to complete, like, let's say I don't have a specific number in my head, but if we're able to do some variation of a double leg calf raise with some load going through the tendon, whether you want to put them on force plates for load symmetry or anything else to kind of monitor that, I'm kind of looking at those pieces as well. So like, what can they do from an exercise standpoint? What do they look like gait wise? How much of a heel lift do we have? And then sort of making the decision from there.
Excellent stuff. So first of all, please do share that article. That's a shameless plug for Journal Club, so maybe an excellent topic for that. You mentioned gait quality. I think that's so important, is just visually assessing that, right? If it looks off, it's probably off. And then two, the inherent values of wedges. We just talked a lot about managing risk. Wedges provide inherent safety blanket or safety net. So excellent stuff. I want to go to Brett.
So as far as like discharging patients, I think now that we have the force plates, that adds a huge tool to our toolbox. I have a guy right now who I'm rehabbing. He's pretty late. I want to say he's like 7 or 8 months post-op. This week is actually his last week because he's moving to Argentina, which I just found out a couple weeks ago. So I have been taking it relatively slow up until recently, just because his strength wasn't exactly where I needed it to be. We've done various strength tests on the force plate, just like seated plantar flexion ISO or like a standing ankle push. And for him, he's been super, super, super eager to run since, I mean, other people at Columbia will tell you who've worked with him. I mean, eager to run since he got out of the boot. He's just constantly pressing us about when he could run. But I think now that we have that tool, and I don't think it's an end all be all, but you can use it very similarly to how we would use like the Tyndek for LSI for a post-op ACL. So it's measured in newtons, but you can still do like follow the 80%, 90% rule. I think is probably a pretty solid framework. And he's, in this case, I think he's just above 80%. So I haven't officially given him a return to run yet. I probably will this week. I'm going to strength test him again just to see where he's at. But, once he hits that 80%, we start ramping up like plyo intensity, plyo volume while still maintaining, strengthening components. So typically what I've been doing with him is we'll do one like, higher intensity, heavier volume plyo day, and then one heavier strength day with some plyos mixed in. And he seems to be responding pretty well. And I think, he's at that point where I don't know if, obviously if he was able to stay for another month or two, I don't know how much longer after maybe February or March he would need to see us. I mean, obviously everyone could always stay for anything, right? Everyone's got deficits to work on, but I think just being able to use the objective data when it's available is super, super important for returning to or discharge.
Brett, what was that conversation like around returning to run when the patient, because we see this in various lower extremity rehabs, when patients so eager to start running, but clinically that's like the last thing you need to do?
Yeah. So, he's the type of guy where you give him an inch, he'll take a mile. So I had to really, really, I mean, it was every single day. He like was half joking when he would say it, but like he's literally the type where he would like fast walk to the water fountain just to see if he could do it. And I'm like, dude, chill out. Like, we don't need to be doing that right now. And he would always ask me, he's like, well, what happens if I do run? And I'm just like, well, you're at a much greater risk of a re-tear. And, back to that conversation we had about how progress is made, I just have to reiterate to him, I'm like, think about where you were, a week after when you came to see us, a week after surgery, and think about where you are now. Think about how much progress you've made. You do not want to risk going back to square one just because you're so eager to run. Like, it'll come with time. And now we're finally at the point where like, we can do, a million pogos and he can break a sweat and almost feel like he's going to run, or bounds or whatever it may be. But I think just like the constant reassurance of like, dude, it's going to come and it's going to be so worth it when you can do it and it feels good, as opposed to doing it prematurely. You're at a higher risk of a re-injury and you might develop some sort of like tendinopathy.
Yeah, all comes back to risk. We'll go to Mateo, then we'll go to Gina.
So yeah, we shared a case and post-op Achilles, which was a very interesting case because it was related to a 16-year-old soccer athlete. And the initial phase, I think, is the most crucial and part of the rehab standpoint, just because you want to avoid that elongation. of the tendon during the early stage. So I tend to be a little bit more cautious, at the initial part. And like Rachel was saying, there's going to be that, 8-week time frame with the boot, where you start with, 5 centimeters wedge, and then every week you start to decrease the wedge height, and then into that transition to walking is going to be critical, like I said, to avoid elongation, because elongation will have long-lasting effects in that patient, especially with young athlete, a 60-year-old athlete, where like in terms of long-term athletic development, he has, high school season, eventually collegiate season, and understanding those early stages and not, I believe there's no such thing in that case of an accelerated rehab. You can be a little bit more less cautious in loading in safe position, especially when removing the boot, starting to, load them, into plantar flexion position with a slant board, and eventually slowly progressing to more dorsiflexion.
I'll follow up on what you said, Matteo, but I want to go to Gina first.
Yeah, to piggyback off of them, I think that like the biggest thing to remember and to go off of Rachel is walking is like 2 to 2.5 times your body weight, I believe, on your Achilles tendon. So if you are loading that person and you're drastically underloading them and you're taking them out of the boot, they're already getting so much strain to that tendon. And if they're not strong enough to resist it in just how much you're letting them walk, that's already going to contribute to like that elongation process. So I feel like this past year, at the same time, Matteo and Jeremy had the 16-year-old, I had a 38-year-old, and it's a firefighter. He's 250. So the load that I was giving him in the beginning was not enough to catch up with how much he was trying to like overdo in terms of the walking. So I really had to sit him down, like make sure that he had supportive shoes, make sure he had a little extra cushion in there, and really take his time, because it took him a long time for him to get to that weight tolerance on that side to be able to tolerate those prolonged times walking. So that was definitely a very interesting comparison towards this smaller 16-year-old versus the guy that I had. But it makes a really big difference. So that time in the boot is really crucial to set you up to be able to load them well once they're out of it.
A couple things that Gina and Matteo just talked about is, I think one of the issues or challenges of Achilles tendon rupture rehabilitation is that a lot of the side effects are more chronic and more gradual than, say, like an ACL, where you're going to re-tear. The re-tear rates on Achilles ruptures are actually pretty low. And I think doctors look at that and it's like, hey, it's safe to return. But when you start looking at function after Achilles tendon repair, it's completely different. And so it's like everything feels fine. I don't have a lot of pain, but I cannot get off that side. And then all of a sudden you start to load the other side or your hip. And so it's what Matteo talked about is those first 12 weeks. It's like there's a lot more harm than good than you can really do. And so one of my core philosophies around Achilles tendon ruptures is that I am much more earlier to load, so around like 2 weeks, but I am much more longer to keep the boot on. And so the boot is almost a tool to allow me to get more strategic loading. And then I put the boot back on for that protection or that managing of risk. And so I've had, a post-op doing BFR 2 weeks, inner range isometric. You don't tear your Achilles in inner range positions. It's the deeper, more elongated positions that are going to be more concerning. So you can be very, very aggressive during those early stages with isometrics, with inner range positions. And then as time goes on, my confidence interval that they're going to do well at 8, 10, 12 weeks, going back to what Rachel talked about with the gait, with the wanting the quality of their calf, things like that, you start to say, all right, I feel very confident based on the work that this person has done over the last several weeks that they're ready to go on with their other life, versus saying, hey, we're at 10 weeks, let's go. So great stuff. I want to go to Josh for some real world examples on this stuff. So Josh, bring it home on this one.
All right. Yeah, you guys might know I had an Achilles repair October 10th. been seeing Zach Kaminsky for PT, so just want to shout him out. But yeah, I think protocols vary a lot because surgical techniques vary a lot. At least that's one reason. So I think it's important to at least respect the protocol. Some docs are doing these like insertional repairs into the calcaneus. So just knowing what you're dealing with. But yeah, my process for getting out of the boot was, I think we were hammering especially gait quality and making sure that I was walking well in the boot. And then as I started to come out of the boot, it was actually more of a gradual process. So I would be out of it for a few hours at work. And then once I started to notice, and like you said, Jeremy, like soreness wasn't as much of an indicator for me as fatigue was. So once my gait quality started diminishing throughout the day, that's when I would put the boot back on. So I think just kind of respecting like tendon loading rules and tissue responses that way.
And it doesn't have to be an all or nothing. And like you just said, how much walking? Like, are we dealing with an athlete that's going to school and they're going to have to walk 10 minutes between classes? Does their job demand you being on foot all day? Like, if you have to be on your feet all day, then you might be in that boot for a very, very long time. At home, you might not need it. And then it's just being smart and not following that timeline. But excellent. Okay. Zach and then Yoni.
And then
I'm sorry.
One more thing that I think was useful is I transitioned into shoes with a rocker, which makes it so much easier to walk and takes a lot of load off of the Achilles. So I noticed I could spend more hours in my rocker shoes than in my other shoes.
How long did you keep that rocker in for, or how long did you use the rocker?
So it's my main shoe that I still wear to work. It's the Glycerin Max. So yeah, I'm at like 15 weeks. I'm still wearing it.
Zach?
Just with Josh's situation, we had to be sensitive to him being up on his feet for a long period of time. So, mixing in boot parameters, but also like in boot weaning. Spend the first, 3 patients without the boot and then put the boot back on when able. So something like that. And then also just want to, I see a lot of newer grads get into that, thing. Josh and I jokingly call it boot camp. So it's just like long arc quads with the boot, single leg squats with the boot, lunges with the boot. It's like, you got to get them out of the boot and do some functional loading and get out of that. That does have its place. Like when it's like very early on, you're trying to reduce the amount of deconditioning that's going on with all the other musculature. But you got to get out of that mindset sooner rather than later to work on like the actual ankle. So that's all I wanted to add.
Absolutely. Yoni?
Yeah, I was going to say, Jeb, piggybacking on what you said about no one tears their Achilles in high ranges of plantar flexion and kind of keeping them there. That usually happens with an eccentric load or at the bottom towards dorsiflexion. I think we all talked about load and we talked about gait. Think about the neuromuscular component and the ability to activate gastroc and soleus and how that just goes in the toilet when they're sitting in the boot. And so, yes, load is important, Gene. It's important to figure out the body weight percent of which you're loading them, but also think about use of stim, focusing them on gastroc soleus contraction, because I think that goes to hell, and that's why the forces go up so high in the Achilles versus in the muscle belly. So it's a great way to start safely getting them out of the boot, putting them at end range plantar flexion, ripping them with stim. We know that BFR increases contractibility of a given muscle. All important things for our PTs to be thinking about as we're getting them back to return to walking, return to function.
Yeah, it's insane just how much atrophy occurs in the whole gastroc and soleus. It's sort of like the ACL, right, with the quad, right? And then it's worse, and you got range in your tendon. So yeah, it's a very challenging rehab, and I think I mean, fortunately, but unfortunately, we don't see a ton of these, right? They're not as common as, say, your ACLs. They are on the rise. I mean, we had our first 16-year-old one, this used to be an old individual one, 40 plus, and now we're starting to see these into pro sports and into college. And I do fear with the way this youth sports specialization that in a couple of years, we're going to start seeing more and more in high school. But again, we'll talk about that when it comes. Okay. That is all on Achilles. If anyone else had any questions, I want to move on to the next topic. Nick, did you want to add something?
Yeah, I just had a couple more questions. They're kind of like specific things, but
sure.
Like what, I guess as far as like dorsiflexion, range of motion, obviously we're not pushing that for quite a while, but I guess at what point, like let's say they're 10 months out and they're still missing 10 degrees or something. At what point do you start to push that? I know like I've just been doing like loaded, I don't know if you call it mobility, but like, calf raise off a step and they're stretching that a little bit. But I guess at what point, if they're like a year out and they're still missing some dorsiflexion, like are we okay with like leaving them at say 5 degrees under the other side and that'll come back over time? Or I guess like how long do we want to wait until we make that full, or is that something we're worried about?
Does anyone want to take that question from Nick?
Yeah, I can.
Let's go to Josh, and then I also want to get Rachel on this one.
Yeah, so I think a lot of protocols do allow you to start stretching more aggressively at I think it's the 5 or 6 month mark. Biggest risk of tendon elongation is early, like up to 12 weeks, but it can occur up to a year after, over the course of a year following the procedure. So I think you can start stretching more around 5 or 6 months, but if they're within 5 or so degrees of dorsiflexion, I think you can expect that to continue to come back. It has to be a balance because a bigger risk of Achilles rupture is limited dorsiflexion. So if they're very limited, I think it might be worth it to stretch, but I think it's like a pros and cons, got to weigh your risk.
Thank you. Rachel, do you have anything on this one or?
Yeah, I think this one's interesting. I agree with the not stretching early on, from the standpoint of avoiding tendon elongation as well. I think that's a big reason. Another reason why the protocols limit it early on is just making sure that we're not contributing to what I feel is a little bit of an inevitable tendon elongation that happens with healing after these and can contribute to like functional loss with like heel raise height and different things like that. But I also think it's important to figure out why they're limited in dorsiflexion, because it's not always gastroc extensibility, right? Like they're in a boot for this long. We're expecting some like arthrokinematic changes at the ankle. Is it like a talocrural subtalar joint restriction? And could you address it with a lot of aggressive joint mobilizations? And arguably, if you have the knee inflection during some of these joint mobilizations, and even if you put the foot in dorsiflexion, if you have the knee inflection, you're putting the gastroc a little bit on slack. So you can work on some of these things, I think, without overstretching the tendon, but would definitely not think about joint restriction as a factor.
Andrew?
Along similar lines, I'd also be concerned about not addressing that range of motion, because if they go to drop step or back step and they no longer have that range of motion, the pressure on that insertion is going to be massive and they're not going to have the strength to control that. So again, not that the re-tear rate is extremely high. We talk about Achilles tendinopathy developing at that point. If they don't have the range, they don't have the strength. Definitely won't be there if you're not addressing at least some of that active control net and range dorsiflexion, range of motion.
Yeah, and something that both Andrew and Rachel just talked on is like, at what point do you start really loading into dorsiflexion? And so, I think kind of, we tend to think, inner range deficits are so important, and I believe they are. But we really need to get strong in end range, outer range positions, those lengthened positions. So, once we're past 4, 5, 6 months and we're doing our calf raises, I'm starting to get progressively off a step, right? We may start neutral and then I may go off a 10-pound plate and progressively get into more, because if they're doing a back pedal to re-acceleration, you better believe they're going to be hitting those positions. So I need to expose them in rehab. Also, we know that progressive strength training through larger ranges of motion can improve range of motion. So I think it's an important thing to think about, as we talked about with John earlier about transitioning to performance, but also the medical side of things is that you do have to expose them to dorsiflexion, and not just passively, but under load, to get some of those architectural remodeling that we want to see happen. Anything else on that? Excellent stuff. Okay, I want to switch gears here. Lucas submitted a great topic, and Lucas, feel free to chime in here, and you can kind of direct this one how you want. But the topic is on managing the stiff knee, which I think is a great foundational concept because we do see a ton of ACLs. So I think it's important to start with the question of how do we prevent knee extension from becoming an issue in the first place? And then we'll talk about what to do when it becomes an issue.
So I originally framed this question as more of like a cyclops lesion kind of deal. So like things that we found is we've had a couple more in clinic recently, and then anecdotally some things that we found, and that so it's like management, somewhat prevention, and then as well as like what happens when they do have it, right? Sometimes it's not totally like on the patient. So how do we get ourselves out of that situation, and what happens post-op care? Because I don't know if that's totally clear cut. And I feel like sometimes trying to get that across to patients is tough. Anecdotally, I find that like some of the patients who are more at risk for it are the ones who really just don't seem to like understand the initial importance of that. Like a lot of the patients that I have don't understand the early mobilization stuff, and usually are a little less compliant on the homework end. Like the ones that I tend to find myself and tend to like see with lesions and stuff like that are the ones who you're kind of like, hey, have you done your homework? And the answer is kind of like, yeah. And you're like, how many heel pops have you done? And they're like, I don't know, like a couple. And you're like, what, 30? And they're like, yeah, something like that. So it's like, it's one of those, like, it's very clear that those patients don't always like get it. So the emphasis on education and the range, I've had talks with Tim about this too, where it's like sometimes the parents use this as a lesson to teach their kids like responsibility. And it's like, yeah, that's not really worth it, because you're asking a 15-year-old to be responsible for themselves in that moment. And I don't know how well that goes sometimes. So it's honestly like kind of like putting it also on the parents to be like, hey, let's not do this again. That would suck. Let's not do a second surgery. Financially, that's probably not a good option for anyone either. So let's make sure everyone's on the page. Mom's allowed to yell at you. Dad's allowed to yell at you. Everyone's allowed to yell at you, so that we're all on the same page as far as doing that stuff. I think that's like huge, because I think that's like we could prescribe them and make them do HEPs all day, or prescribe an HEP all day, but like the adherence to the 23 hours that they're not here in clinic is so important. And I think some of the kids don't necessarily get that. As far as after that, I was curious to hear what everyone else kind of does post cyclops lesion. So like if they have a surgery to remove the lesion, what we usually do is we try to have them there as much as possible. So if they get the surgery on Monday, it is Tuesday, Wednesday, Thursday, Friday that they're going for it. And they're going to be here. We're doing a lot of joint mobs, extension work, and just trying to like get every part of the quad fired up, especially since like I have one case where the guy's had a cyclops for over a year now. No one caught it, and I guess I was the first person to, and he just struggled. He was like struggling with painfulness because of just like the way the kinematics of the joint are like altered after having a year of not having regular mechanics. So just curious more from everyone's standpoint of like, what are things that people are finding that are successful, unsuccessful, that kind of stuff.
Andrew?
Go ahead.
With the exception of one physician, and I'll talk about that exception in a minute. Usually we're trying to get them in the same day. If they have a scope or a lysis or manipulation, they're going to be in PT the same day, which I warn them ahead of time is going to be very uncomfortable, and they're not going to feel great because they're going to be coming down from anesthesia, but it's the best time to start that process to make sure it doesn't happen again. And then typically I'm telling my patients and my teams that they're going to be in PT 5 days a week for the next 5-6 days a week for the next 1 to 2 weeks to make sure we don't have an issue with that again. The only other, and that's usually not a problem, it usually goes really well. And then within, 3 to 4 weeks, they're feeling pretty good from me in post-op again, if they do have a lysis and it's invasive, where they're almost back to where they started before the surgery with less pain. And usually that quad's firing a little bit better because they actually have full range now. The only exception that I had a physician who liked to cast his patients post-op. He would lysis them and then put the entire leg in a straight cast, which I felt was then difficult for us to do our jobs. I would still try to promote passive extension as best I could, but there's not a whole lot you can do when that leg's casted for, I believe it's somewhere between 7 and 10 days at times.
Yeah, I think I'd agree. Like 5 days a week, 1 to 2 weeks for sure. That's like seems to be the standard for that. And hopefully you're doing exactly what you're doing day one that you didn't do and getting there. My question on this would be, when do you all start to get concerned that this knee extension deficit is a surgical issue and it's not going to change with rehab? At what point in the timeline do you start thinking, okay, I need to talk to doc. I need to start kind of getting that conversation, that ball rolling?
Herdy's got one now, by the way, so eventually gets a Herdy.
All right. Let's go Matt, and then we'll go to Lucas.
And Liv can help me out on this one too, because he kind of consulted on it. We actually had one probably dating back about a year ago since she had her lysis done, but we were treating her roughly for about 10 months, a little bit like she was a college player, so a little bit of time at home with her PT at home and stuff. She was able to, like, basically every session would start off like working on getting full extension. And like she was able to get there, but she was never coming in with that full extension. So me and her PT kind of, I want to say she was probably about, and this is where I kind of start to, which is where I start to kind of think about it if I need to, somewhere in that 3 to 4 month range. If they don't have a good, consistent heel pop, then I start to kind of start questioning it and maybe mention something to doc like, hey, I'm a little concerned here. So I usually go in that like 3 to 4 month range. We had like basically argued with the doc at starting at like 5 months that we think there was something going on, and took us another 5 months for him to actually do a MRI to see that there was a cyclops lesion. But to answer your question, somewhere in that like 10 to 12 week range, if I'm not seeing a consistent good heel pop right off the jump without a warm up, like if they're not getting a little bit extension without warming that up, then I start to kind of raise the red flags a little bit, and I'll usually text or email the doc like, hey, I'm having some concern here. Next time you see them, let me know what you think, etc. But I'd rather try to be a little bit more on the cautious end and alarm it early than wait too long.
Yeah, and like you said, like 10 to 12 weeks, it's like anecdotal. I'd love to hear from all of you, but a lot of doctors don't like to go back in before 10 to 12 weeks anyway. So, okay. Thank you, Matt. Let's go to Lucas.
I'd say yeah, I'd agree with the 10 to 12 weeks. Like, I think I've identified some of them like with stiffness issues early, but you'll like tell the doctor at 4 weeks and they won't touch it. And they'll wait till the 12-week mark and then put them on a steroid pack. So usually the earliest they'll even get to it is 4 months, like 16 weeks down the line, because they like wait that whole time, see if the steroid pack. And I have seen the steroid pack work to some extent, so I'm not saying it doesn't, but I feel like it's just a little bit more hit or miss at that point. I think I'm on it as early as like 2 weeks to notice it. The 2 week mark is, so if it's a clean ACL, the 2 week mark is just more like, hey, you should at least be able to walk in with passive extension. We're not saying heel pop is super clean. We're not saying it's like totally like there, but they should show signs that it's like on the progression, it's on the rise. But I think for me, it's like sometimes it's like if I'm doing a ton of manual and then the next like and we get it in the session, but then the next session they come in and I'm doing the same amount of manual, the same amount of stuff, and I keep like the next 2 weeks is just that. I start noticing and being like just like this is weird. Like something's really, really off about how much work I have to put in. Usually it's like if I'm spending 20 minutes on manual just to get it there, they come in, I measure it, it checks out, and then they come in again and it's still lacking. It's just some of that stuff that just makes me really nervous about that stuff. And I try to get them ahead of it too. And I start having a lot of those early conversations too with parents and patients too. Hopefully, if I get it with a parent, like they're yelling a little bit at their kid to like get on it. And sometimes that cleans it up, but also like pushing on them the importance of like, hey, this is a team effort. We got to do this because a second surgery is likely. So something as early as 2 to 3 weeks is usually how I find it.
Right. And it's like if you don't have extension at 2 weeks, you know it's going to be an issue at 4 weeks. If you don't have it at 4 weeks, you know it's going to be an issue at 8 weeks. So it kind of just the longer you wait to get it, the more it becomes an issue. So thank you. Rachel.
Yeah, it's just kind of going off. I think this echoes your point, Jeremy, about like how important the early stage of Achilles rehab management is as well. Like if kind of like what Lucas is saying, if you come in like visit 2 after ACL and I can tell you didn't do your homework, I already know there's going to be like a problem down the road, if that sort of makes sense. So it's kind of the people who I think are affected by this, and whether it's like a cyclops or like anterior interval scarring or whatever it is, like the people who are more prone to this are the people who are almost like either scared to use their knee or use their knee like too much, if that kind of makes sense. So I think just like laying the foundation early and being like, hey, like this is a very important rehab. Like he said something like you're doing 30 heel pops a day. Like, no, like there are protocols that say 500 plus quad contractions a day. So I think that piece is really important that we're layering that in early on. And then to the 10 to 12 week mark on a surgeon might not touch it before then. I think that if I'm catching someone, let's say we're 6 to 8 weeks out and their heel pop's not clean, and I kind of think this is going to be a problem down the road, and challenge me on this if this can be wrong, but sometimes I almost shift them a little bit more to strength progressions within like a range that they can do. So if they can't hit terminal extension, I'm still going to target quad in the ranges that they can get, because their activation might be better in those regions, and then expecting that, okay, we probably need a lysis. Like if we're pretty dang confident that we are, then at least I'm getting something progressive with them in rehab versus me cranking on their knee for 45 minutes and not seeing progress. I'd be curious kind of anyone's takes on that. So we have gotten people, they went somewhere else for like a month or two and we are not seeing changes, and that lysis is almost inevitable.
Rachel, we'll come back to that topic. I want to go to Sarah and then Ethan.
I kind of have a couple things that I want to add in, but I know Lucas talked about it a little bit in terms of like what they're doing at home. I have a lot of patients who their parents are like trying to teach them responsibility. And again, it's like this isn't the point to do it at. So for me, I've kind of taken the side of if their parents aren't going to help them stay on top of their own rehab, because I'll have a lot more like high school females, just high school patients. I term it as like my accountability program. I make them text me some form of extension 5 times a day for 2 weeks. And it can go longer or shorter. And then after that, I kind of give them like a little reward system as like, and if you can do this every day, like I'm going to get you something.
Yep, Bubba.
Found that to have a lot more carryover in terms of one, now I see what they're doing at home. So like I had someone a while ago text me and she was doing prone hangs. And I like filmed everything in her app, set it up perfectly. Table was supposed to end at her knee, like your typical prone hang. She sent me a picture doing it at home, and her table's ending at her hips, her feet are touching the ground, and the backpack's resting on the floor. And I'm like, that's not a prone hang at all. Once we fixed that, everything started to clean up. So kind of addressing the side of like, hey, what does your home program, one, look like you doing at home compared to when I set it up? But then two, actually making sure that they're getting it in the same number of times a day as you want them to, or at least more than just like going home and doing one a day.
I love the value of the ongoing communication. So important. Daily text or updates. That stuff goes so far in rehab. Excellent stuff. Let's go to Ethan.
Yeah, so Yoni alluded to it earlier. I have a kid currently. He's just hit 9 weeks post-op now, ACL and MCL. But looking back, I saw some problems before surgery. We were able to push his surgery back, but it took a lot of legwork because the surgeon isn't somebody that typically communicates with physical therapists well. So it took a lot of texting the patient, hey, these are the things that I need you to hit on. Family's also not very health literate, so they needed a lot of handholding there. So being able to work with your family, one, is really important. We have an ongoing group chat of weekly updates. Hey, here's where he's at. These are the next couple steps. These are where my concerns are. Here's what the next 4 weeks needs to look like in order for this individual to get the care that they need. This is something that I was concerned about 2 weeks post-op. He was missing a ton of extension. The end feel just wasn't good. His swelling was fairly well. He was very diligent about the exercises. So once we figured out and tried to perfect his exercise program, we rechecked it after a couple weeks, and it just wasn't really getting better around that 4 week mark. And I would say that's when the conversation started with the parents of, hey, this isn't moving in the right direction. His end feels aren't feeling right. It's really sticky. He doesn't have a lot of swelling. He doesn't have any pitting edema late in the lower limb. This isn't going well. But kind of where we're shifting now, to echo what Rachel was saying earlier, is the value of having the fail safe. I know Jeremy and I shared a patient a while back that he was also a multi-ligament repair and reconstruction and really struggled with getting extension back. But doc did not want to go through with the arthroscopy. So, we decided to put our heads together and utilize that available range technique and kind of use the backdoor approach. And this individual ended up, regaining a decent amount of extension, not nearly as much as his other side, but had some resemblance of a normal functioning knee. So that's kind of where we're preparing to go in these next couple weeks. We're just some closed chain, some open chain, two tolerance, have a daily update on, hey, how did that feel? We don't want any sort of, adverse event, any swelling, pain, or loss of range of motion at this point. We're just really judging off of what he's doing day to day, and how he's feeling on that next day of where we're moving forward. But that's kind of where my head's going. My goal is to have him in front of the doc at 12 weeks, so we could, at least start that steroid pack, or have, a surgery on the books around that 16-week mark, hopefully. But
No, and Ethan, you mapped out that timeline well, and sort of what you said kind of coincides with what Rachel said earlier about what to do when the doc wants to wait, right? And do you just continue trying to hammer things in versus switching gears and focusing on a little bit different things? So thank you, Ethan. Let's go to Andrew and then Mateo.
I want to circle back to something that Rachel said, and Ethan, a little bit of working in that strength range that they have. I think it's really important that we try to still push that end range of motion, because if we don't push it at all, it can get worse. Now we're not even close to zero, let alone 5%. So I think that's still important on top of being able to work on global strength ranges of motion. The other thing I want to touch on too was there are some therapists, and this is me anecdotally. There are some therapists that think they push through some of that scar tissue. Number one, I do think it's possible, but there has to be the certain kind of patient that has the ability to withstand that kind of discomfort. I've come across, I think, 2 in the last 5 to 6 years, been able to, and that's because the surgeon just wouldn't do a lysis. 2, even able to actually push past a really significant amount of scar tissue. One was with Zach Adams. We treated, it was a multi-leg with a peroneal nerve injury as well, where the physician did not want to do a lysis. And so that kid had a mental fortitude to be able to handle that kind of discomfort, and we got him back. It was not fun. It wasn't pleasant. and it was a long road. The other one is someone that Brennan and I recently eval'd that I was very concerned about having too much scar tissue. He came to us from somewhere 3 months out, did not have full extension, and the end feel was some kind of bigger cyclops lesion, and couldn't get a heel pop, couldn't get great quad activation. But when you were able to push into him, he was able to tolerate it. Not everyone can tolerate that. So my point is that yes, still push for it, because you may not, it may be 3, 4, 6 months before a doctor is able to do or wanting to do some kind of lysis. So not working on it at all, I don't think is the answer, but also just beating it to death and not doing anything else isn't the answer either. So kind of blending what Rachel was saying as well as that patient with a surgeon or physician.
A blend and a balance is for sure needed. Okay, we'll go Mateo, then we'll go Danny, and then we'll go Abby, and then we'll finish this up. So let's go Mateo.
Yeah, for me, like a KPI, for regaining full passive extension, for me, I want to have passive extension at 6 weeks. Now, there's going to be some periods, where they lose that, depending on standing, school, all those factors. Going back to the heel pop, right? Like that could be also initially due to a motor control issue, right? So the first thing is, can they get there passively? Okay. Then once they get there passively, okay, then we can start with more stem unit, more that motor control into that inner range position to get that quad going, decreasing the AMI, orthogenic muscle inhibition, especially after, bone patellar tendons and quad tendons. So yes, like for me, is can they get there passively? Can they maintain that passively? And 6 weeks is kind of my time frame, but also I don't neglect flexion as well. Most of the times these people, they can do all the propping they want, the low, long duration, and depending on the tolerance on how they can handle that low, long duration, we know that, in order to see those viscoelastic creep effect on the connective tissue and the remodeling, it should be approximately 8 to 20 minutes. Initially, they probably don't tolerate as well. So microdosing that maybe 8 minutes. Okay. Then working on your quad set, then going to some knee flexion, because the knee is going to feel a little bit stiff. So you need to keep moving. So it's not just about extension. For a homework perspective, I give 3 things, propping, NMES, quad set assisted, and then some sort of knee flexion component to try to decrease that stiffness aspect of things. And yes, there has to be a diligent approach from the patient, and the communication is very important, but we can see if they're doing it or not, when we see them in rehab, and we can hammer that educational aspect as well. And just give them a little bit more control on they need to do this, in order to, it's for their own benefits, to avoid potential, scarring down. And we know that certain populations have the tendency to scar more than others. For example, like African Americans have the tendency to scar a little bit. So those are all things that you need to, discuss, not just with the patient, but also with parents, and find the right wording, going back, to what we talked and discussed about before. So that for me, like the goal is to kind of can maintain knee extension 6 to 8 weeks and attain and achieve also full flexion at that time.
Excellent considerations from Mateo, and especially too, like don't dismiss the value of flexion in helping you achieve that quiet knee and asking why extension is limited in the first place. Okay, Danny, what you got? Danny, I think you're muted. There we go.
Sorry, I double clicked it. All right. It was perfect time for Mateo to mention that, because I'm hoping it wasn't going to derail the talk about extension. We've had a handful of patients recently in New York that have had a significant limitation in their flexion. And while their extension has looked good, the way we usually talk about it as a staff is when they get to those sticky parts, the more that you work on extension, it seems like flexion goes the opposite way. It's almost like a teeter-totter. There's one that we just collaborated on with Columbia and a fantastic doc. It's Dr. Dries, coming out of lysis, and this kid is still struggling on his range of motion. So I think early notification for the doc on exactly what's going on, that transparency has been helpful on our end. I know some docs are like, well, I've already done the lysis. I don't know what to expect now. I think it was 2 or 3 speakers ago that had mentioned when they don't have the range before they go into the surgery, that is a significant limitation. And sure enough, we find out probably about 6 weeks into this specific patient's care that after he tore in August, I believe it was, maybe September, he never got full range back. And that is, I think, such an oversight sometimes heading into that surgery. Most docs are really, really specific about that. I realize they kind of have to treat what they get handed as well. But we've seen significant guarding, significant tone in that flexion. And I kind of want to pose that as a question to the group. How often is everybody else seeing flexion limitations? Of course, extension, like I had said, is our early focus. But like we use the bike, we use wall slides, all that kind of stuff. What does everybody else do when flexion starts being super limited?
A really good question. Does anyone have an answer to that one? Specifically, hands raised for this question.
I was going to bring up a point too, since we all know the patient that Danny's referencing. Even after they did the scope and like he only got to 120 flexion, like in the operating room, and that surgeon's great, but then it's kind of like we had him at most 70 or 80, and I'm like, I'm going to use the term rude. I'm like very rude to patients when we need to get motion. So I normally know if I can't get it, it's a problem. So he goes in and, comes out and he looks within a few days, like pretty much how he looked pre-scope. And I mean, I'm happy that, I'm engaged to someone who's kind of smart, who told me to look at the post-op report as to how far they got him. And I didn't know if anybody has noticed that, like, all right, goes in for a scope or manip under anesthesia and only gets this amount of flexion. Like, is it going to make a difference or not? I guess also looking for guidance there, but wanted to put that into context for people.
Yeah, that's such a hard question. Like, I don't know how many times I see flexion limitations. Like, certainly I'm wondering, like what is the pathology, if it's a posterior meniscus issue, if there's some sort of bone bruise that's painfully limiting into it. And then if you're driving into it, it's only going to make it more swollen and effused. Also, are they in an extension brace the entire day and not taking their leg out of the brace? I try to get after flexion hard early. A huge KPI for me is 90 degrees by the end of week 1. I don't care if they have a meniscus. I don't think that much flexion is really putting stress on the meniscus unless I'm going in deep ranges. But I think flexion, like Matteo talked about, is so important early and often. Every hour, can you do 10 knee bends an hour? Just getting that knee constantly moving, so important for mobilizing scar tissue, preventing swelling, effusion, all that stuff. So I don't know how often I see it, but it's one of those things. It's like if you don't pay attention to it and it creeps up onto you, you start asking why or wondering if you missed it or like what else, where else. So good stuff from Christy and Danny. I know we're a couple minutes over. I want to get to you, Abby. You've had your hands raised for so long. Can you bring it home for us today?
Yeah, I was just going to also add in when to get that patient like another opinion, because I had somebody that came in 2 weeks post-op. He was lacking like 30 degrees of flexion to neutral. And so I was kind of like, right away, this was doomed. Tried to go back with his doctor at like 4 weeks post-op. Didn't do anything about it. No steroids, nothing. Even at the 12-week mark, his doc wouldn't do any steroids. And then at the 4-month mark, he wanted to put him in a Dynasplint, which is not going to get hyperextension and is usually used for like knee replacements. So I ended up telling him like, hey, maybe you should get a second opinion. And he went to Dries, and Dries did the surgery within like 2 weeks, and then he got back. So if you're really trying to fight with a physician, you can always, if you know a surgeon that might
see that patient, get them a second opinion. They can do what they want with it, but I think that's also important.
No, second opinions can be so valuable as long as you know how to walk that line. Okay, everybody. I'm sorry we went 7 minutes over. I had a whole nother topic on upper extremity to get to. If we have another snow day, we'll lead it off with that. Hopefully Yoni's crossing his fingers it doesn't happen. But guys and girls, I really appreciated this. This exceeded all my expectations. I hope you all took something away from this, and I just appreciate you all chiming in. I know I learned a lot, and if you can, please try to make it to journal clubs. These conversations are so fun, so good. I love them. So thank you all for coming, and sorry I went over.